Those cases were not treated by the regular protocol. They didn't come at the correct time, and they went to different treatments, and they come to you. And then if it's still possible, Ponsari method is a good way out. So let's see. So how late is too late? Yeah, we've been seeing lately lots of groups pushing the limits, okay, and doing some adults with deformities that were completely prohibited to be tackled by the Ponsari method. The truth is, what is the price to pay to correct them with serial casting? I think this is the question. It's very important for you to ask yourself and to ask the family if they are ready for this, because it's not a magic solution. It can impair the functioning of the whole family. He has to have somebody to take care, and wheelchair and independency of this person. So this could be an alternative to open releases, tarsectomies, modulating arthrodesis, and external fixators. And I think it's not that you know how to do Ponsari, so you should do for everything. But I think there are some considerations we should put on this decision. So putting 84 casts is not a good idea, because we've seen in cases, some anecdotal cases for China or any other places, that the osteoporosis is very bad, so they will have stress fractures. And they will, I mean, you can move the foot around, but maybe the joints will not follow. Maybe we'll have contractures, and contractures are very bad to treat in older, let's say, young adults. And that could be a problem to get all these people stand up again. Get back to walking. So as I told, stress fractures. So as you can imagine, social and economical constraints. So the person is there, needs somebody to take care, to be running around. And of course, the families had to cope with the treatment and understand it and support it. So it's not for everybody. It's not for every foot. Well, as you saw, the Jose already showed this 16-year-old. So it's possible, and if it's 6 casts, it's a valid solution, because then this kid, what happened is that he was painful for a while, and then he didn't use any brace, and went back to soccer 1 year after, and everything was okay. So I saw him at 1 year follow-up, and he was getting out from this painful situation, and he was happy. But that's not what is everyday life. So I think it's for you to decide on going on this or not, you have to measure, okay? If you, as I was saying in the previous lectures, if you're not able to measure, if you're making any progress, you should stop, because you have to see what is the problem. It's a bone block, or if the skin problem, or if you go into very much abduction, the first Ponsari Symposium International in Iowa, there was a presentation by doctor from Philippines, Dr. Julina Aguiar, and she showed me the audience very good corrections, but very weak feet. And she went into a very much like 70, 80 degrees of abduction, and she could correct without the tenotomy. So she was happy not having surgery, but the feet were completely weak. So all of them needed AFOs. So that means that it's strong enough for you to do the method, but on the other way, you lose a lot of strength of those feet. So you have to decide what's ideal and what's your goal. So if you go too much in a foot that has already been operated in posterior medial release, it's very unpredictable. And then, not in a non-touched foot, but on an operated one, you can have a very bad planovalgus foot, and I have one to show you. So that was my first case when I came back from Iowa and Baltimore, and then there was not a baby waiting for me. There was this 6-year-old, and so I talked to the family, so let's see what happens. And then 6 casts, the hygroma disintegrated, and he had you know, I did an open the lengthening at the Achilles, not anymore, so only tenotomies now, because, you know, don't have to be afraid. There's enough restrictions in the capsule and all the soft tissues to hold up, so the foot is not going to plantar valgus, which could be a fear to do the tenotomy. And here he is at 8-year follow-up, and the X-rays show good correction and alignment. So we got very excited to put together a study with more people to make a good retrospective review, maybe to decide on the ideal protocol of those feet, what to do better. So we got together in a group. We offered this study to lots of people, and then 9 people from Brazil responded with cases, and also from Mexico and Ecuador and Colombia, and also India, Egypt, and Pakistan, so with cases. So we put them together, trying to see what would be the best solution. So first, we did a systematic review on the literature, and what we get, 654 feet, 3.6 years of age average, 8 casts, well, all these authors used to get this correction. Follow-up is not very long, so 2.6 follow-up, and the recurrence rate at 22%. And 10 of those 12 studies used the foot abduction brace. That could be impossible. I mean, they are grown-ups. How can they use the abduction brace? They use, because it's a very challenging situation, so you have to maintain the correction. You won't let go. So they're very important. And even, you see, half of those studies used 23-hour the brace for 3 months. So we thought it would be impossible, but when we tried on our cases, we see in the literature, and there are more people doing that, you know, having good results. So 84% of the total results were no deformity and plantigrade, with 11 degrees in average of dorsiflexion. So those are very astonishing results. So we tried to compare the results we got from this group. So in the follow-up, we also didn't have a lot of follow-up, so 23.2 months and 429 feet. So compared with the systematic review, so we had a big number of cases, and the average number of casts 6.7 from 3 to 4 to 12. Percutaneous tenotomy in 81%. Look at that, local anesthesia on 72%. So considering all these developing countries also. So general anesthesia 27%, and complication rate 0.2 per patient. So the protocol of the brace, all of the authors of these 15 groups used the foot abduction brace. 12 of the 15 authors used 3 months continuous after correction, and then nighttime use up to 4, or if older, 1 year after the correction. The relapse rate was exactly the same as the review from the literature, 22%. 70% treated with new casts compared to the systematic review numbers, and 32% had the follow-up over 2. Of course, a follow-up less than 2, we cannot infer a lot. So 18% had anterior tib transfer and the tenotomy, and 37% of those anterior tips were primary, means that they were used to treat the initial case, okay? And the others were just after some recurrence. 20% that had no adhesion or had barriers to the foot abduction brace protocol had 60% relapse rate, as we know, and 80% strict to the foot abduction brace had a relapse rate of 16%. And we had 5% of posterior medial releases at this follow-up, which is about 2 years. So if we compare the ages, that we should think that would be a big difference between the ages, so we had good numbers to break those groups. You see there's not a lot of difference in considering Pirani's initial and final, and or even ankle dorsiflexion, or even as we graded excellent, good, regular, and bad results based on our study from 2011 that defined that excellent would be no deformity and more than 10 degrees of dorsiflexion. Good would be no deformity and less than 10 degrees of dorsiflexion, between 0 and 10. Regular, any other surgical would be needed, like a shortening of lateral column or other surgery. And bad was the posterior medial release. So considering all these, there were no big difference between the ages, which was very striking and interesting. Of course, it's a retrospective, but still. So some cases, so Dr. Nariman from Egypt, so it's not okay correction, it's a good correction. I think this is very important because as we've seen presentations where the feet were not so great, so those are good cases, as you can see. And those are from Mexico. So in the discussion, the foot abduction brace in any age, it's very important. So we have higher relapse rate without it. So it's soft tissue problem, so you have to stretch it if it's in a grown up. The similar average catch number, relapse rate, treatment of relapses, and outcomes among different groups. And it's, of course, it's a retrospective review, and those cases were evaluated by their own doctors, which is a bias, of course. So the Ponseti method could be called efficient and should be tried in older children. It's our preliminary conclusion from this study. So this is Otavio, and we brought him also to show the remodeling. It's possible from the X-ray. You can see the big changes. Okay, he was a 7-year-old from the Amazonia that was directed to us by a church when they found him walking around there. And as the same way Shafiq did with the babies, so we did an MRI study, and we can compare the MRIs and see that the remodeling occurs quite well in those 7-year-olds, as you can compare it with the baby cuts. So it was difficult to put this protocol, but we kind of tried to compare, and it was a good remodeling. We also could see that the Achilles tendon healed very well, and those 8 weeks post-anatomy, then 4 years after the treatment. So it was there, healed. So it's a nice thing because many people are concerned if it heals or not heals. Okay, arthrogryposis. So those were cases that we began to treat from 2002 and 2009, 21 patients, and amyoplastic, the majority, some distal cases in the age of the beginning of treatment, 9 months, varying from 4 days to 4 years. And we improved our follow-up in 8 years now. So we got correction, initial correction in all cases. And the number of casts was not very much different from the idiopathic 6. All had tenotomy under local. 2 had other conditions and died. One was syndrome, and one had ventilatory problems. And 44% relapsed. So the relapse, sometimes one didn't want to continue treatment for other issues, for difficulty embracing. One had a tibia fracture not related to the treatment, and they then gave up. And all the relapses, but this one that they abandoned, were treated with new casts, and 3 with new tenotomies at the end of the cast. So we had a lot of pressionary erythema, so we have to take care of those cases like a complex. So the approach Jose described on trying to get rid of the cavus first is very important. And the one that had the tibia fracture as a complication, but not related to the treatment. So after the cast protocol continues 23 hours for 3 months, and nighttime up to 5 years and not 4 because of those changes that Jose described. So the protocol. I'm a cold turkey person because I think we have to be consistent. And for the parents, if you tell one thing, they will follow better than if you try and change. As Jose was saying, many people take the kids to school, and then they have nannies, and there are all kinds of adjustments you have to make. If you at least 14 hours, some of the families will do 12 hours, some of the families will do 10 hours, and you have to examine the food and see if that is okay or not for that kid. Okay, so we push everybody to 14, and we don't change the protocol because of, we think it's easier to follow. Well, about AFOs in nitroglycolic, I was told when I was at school that you had to do AFOs during the day because you had to. But Jose just came to me one time and said, they are rigid food, so why do you need an AFO? But it's true, because you only need an AFO if you have no control, if you have an anterior tip pulling on inversion, or you have no control and the foot is wandering around. If not, if they're rigid, you don't need, and it's better for proprioception and other issues. And it's very, very easy to lose the position of the foot. And this one, just for you to look, it's dirty. The toes here are dirty because I just finished, and when I was going to the other side and back to this, the toes are already in. So they are going to be in, and they are going to be lost. So you have to be very strict and repeat the casting and make the family coming back in 2 days or 1 day, whatever. So if the foot goes back, it means that it's going to be hurt because you molded very well on the dorsum here, so you have problems here. You have problems with the calcaneus when he goes up because there's no space for the calcaneus over there. So what's going to happen? Exactly this. So my approach to those lesions, maybe a little crazy, but it's like a lot of people just stop and let it go for a while and then to settle. But in those very rigid foot, what is going to happen? The dorsiflexion is very bad. It's going to open the wound really bad. So if you have a small wound and you let go, the force of the foot will just open it. It'll get really, really bad. So if you keep casting like a diabetic problem, you keep fighting the pressure on the posterior part, and the wound will be healing and no pressure. So that's my approach to the problems. And it's opposite to simply watch for a while, because then will go bad and they will open, and then somebody will debride, and all of a sudden you're in the talus exposed, and that's very bad. So, and we were talking about rigid bracing for those kids with very rigid foot. If you have a silicone without the posterior support, it won't hold. So simply the foot will go in equinus in the brace. So you have to be, you can watch the ones in the middle, so almost no dorsiflexion, and with the braces, you get dorsiflexion. Those are very rigid foot, so you have to brace it very perfectly. I'm very picky on the brace, and as our colleague was saying, that you have to check the brace, you have to check how the parents put the brace on, and how the heel is adapting there with a hole on the posterior part of the shoe. So it's crucial on those kids. So you see, if it's going up, and you have to check really in a very critical way. So this is a myoplasia case, typical, and here, from here to there, 8 casts. So it's a lot. That one, that is the lady that I had that bad curvature on the tibia, and that's how I got out of it. So after 8 casts, so I fought a little bit, but that she is with 2 years and then 7 years, keeping the correction, with other issues on the knees, but hips also very rigid. Another case, very likely no creases, as you see, and 2 years old, 6 months, and then 2 years old, and then she disappeared. But the corrections was very satisfactory. So at this boy, 12 days and 3 casts, 1 year, 6 months, and then with the problems with the knee, so we braced the knee, put him to stand, and you see how the superior limbs are also committed with the arthrogryposis, but still we can get the correction. Very severe syndromes like Freeman-Sheldon. If you are okay to do a small number of casts and can get away from that, great. So that's what we did. This girl that began treatment very late, as we say, 1 year, 3 months, arthrogrypotic, very rigid feet, also hyperextension of bilateral knees, hip dislocation on the left, bilateral patella dislocation, so lots of issues. So after 7 casts, pretty good correction, and then other surgeries went, and we keep her corrected. So that distal arthrogrypotic, this one was one of the oldest kids in our group. He was 5, and then 6 casts. So this is arthro. So what's different from arthro and myelo? Myelo, we also revised the number, but of course we have no sensibility. So we have to be very, very critical on the model. So the low lumbar, as you can think, are the worst because they have inversion. So sometimes the tendency to invert is very, very strong. And sometimes you have to do tenectomies. You have to take out the anterior tib, and the families are crazy because they, that's the only one that's working, doctor. Yes, it's bringing the foot in again. And the age was a little bit more older. 1 year, 5 months, and 6-year follow-up now. So we did strict pulsating method in the manipulation. Of course, the brace had to be modified because if you do short boots, they will break the tibia. So we have to go on AFOs on those cases because they're paralytic. So you have to adapt, and it's very difficult to adapt AFOs because you have to play with the distance in the bar, but it's challenging, but you can do it. And oh, yes, we had a case of OI that was in the middle. That was very, very severe, and 1 thoracic. So those 2 abandoned treatment, and 2 feet went into the posterior medial release. So basically the case of we went into posterior medial release, we couldn't move because of the block of the subpatellar joint. I don't know if it was because of manipulation, and they kind of melt together, and we couldn't move around or not. And of course, you can imagine the number of complications, they go very high. Dorsal hematoma, superficial ulcer, and tenotomy, not as many as in the arthrogrypotic cases. So 52 cases relapsed, a little less than Jose showed, but almost the same. 6 were back to cast, 5 posterior medial releases, 1 fasciotomy and tenotomy, and 1 did tenectomy 2 times. So just cases, you can progress the same good results as the arthrogrypotic, and you have to reach for the good plantigrade foot, not for a lot of dorsiflexion, so that's why you don't need to do tenotomy in all cases. If you get plantigrade, you're good. So you see a little more rigid and older in the upper part of the slide, and here she was walking, but not walking anymore because of a turning in. And a lot of people would prescribe the rotational osteotomy, but it's a soft tissue problem. So here she is after 2 casts. So in 2 casts, you changed from almost a bony surgery to nothing. It's not the bone, it's soft tissues. And also difficult to handle soft tissues, they're fatty, and you can also treat ulcers, pressure ulcers from the infected. That's why she was not operated, because she was waiting for surgery. Put on cast the same way as in diabetic ulcers, total contact principle. Another girl, and she was 4 at the time, now she's 16, and she corrected well at the beginning. Then she maintained the correction, and now she had a tethered cord, and the other foot got into deformity. So treated the right foot. So it's a game. You have to keep going, keep maintaining correction. So the cases, and this girl on the on the below part, and low part was operated bilateral. She kind of glued the subtalar joint that couldn't move, and then she was operated. And she relapsed after surgery, so we can throw in some casts again. So this is horror show. So those kids, they don't feel. So you have to be the eyes. You have to be really, those were sent from a colleague in the north, and he was completely desperate. And in those went to necrosis and debridement, almost lost a leg. And so you should consider these situations. So a little tip and a trick. So for myelo, different from atro, different from idiopathic or a grown-up, if you take the cast off and watch, you watch for 20 minutes and it will become a bread, okay, because of the vasoplegia. So if you take the cast off and wait, it will be very easy to form an ulcer because of, the foot is completely puffy. So take the cast off and put another one, not even let the child in the bed for these cases, because this is, you see how red it is and how kind of edematic or how do you say? Yes, in red, and then that's 30 minutes after taking out the third cast. So it's very easy to get into trouble after that. So rush, one after the other. Don't wait too long. 2 weeks is too long for those kids. And of course, you see the brace had to be an AFO. Sometimes not a lot of abduction, only needed. Sometimes you have to brace the hips not to go into external abduction. So some physical therapy get a little crazy on that. So osteogenesis imperfecta to add up more difficulties. So it gets challenging and challenging. So fractures look like tumors like that. So it's very scary. On myelo, it's very easy to have. So still, all these difficult cases, you have to have a very good hand on the idiopathic for you to move on to those more difficult cases. Relapses are common, should be treated with new casts. And of course, multidisciplinary approach, especially on those cases, is very important. Well, operated just passing the same case Jose showed. So there was our inspiration, 10 casts, no surgery, and good alignment of the heel, and good x-rays. So those cases are described in the Clinical Orthopedic Related Research, 2009, and 86% corrected and were plantigrade. So the age of the treatment was around 5 years of age. So this one was the youngest, and I have the follow-up on him, 3.5-year follow-up, and then 1 year, 9 months, 3 casts, 4 year, 3 years follow-up. And this was the girl that we went too much. She had a very bad planovalgus foot, 10 casts, very powerful. And as you see, the x-ray, you change from a virus to a extra corrected planovalgus foot, very difficult to treat. And maybe I should have, in retrospective, stopped before. She was kind of okay when she was younger, but when she got heavier, like 7-year-old, she was completely, from the other side, and difficult to treat. And you see the whole foot shift from the lateral side. So you cannot control the tension because it has already been operated, so the tissue reacts differently. Another boy with more follow-up, 8 years, 12 years. Yes, he does kind of circus thing. And, well, the follow-up are those very good, but when they come older, like this girl, they, like the posterior medial release story, they become painful. And they become painful even if the foot is corrected and nice. And sometimes you think that's impinging on the ankle. You can do some arthroscopy. We did. We can do anterior tip transfer and casting. And we finally ended into a triple arthrodesis. So this is kind of hard. And remember, and reminds us that surgery has a price to pay on those kids, sometimes not even too late. And she was in the second decade of life already with arthrodesis. Well, 90% completed the initial correction, 5 casts in the average, some complications, sternotomy in 79%. Oh, so I'm sorry. I think I went the other way. I think this is it. This is it. I finished. I think so. I don't know when it went the other way. Thank you. Sorry about this, so many cases.